Yeah, very good afternoon to you all and warm greetings from Rainbow Children's Hospital, Chennai. The topic for today will be COVID-19 in children, the clinical spectrum and management. There are three speakers for today. One is myself, Dr. Ganesh, as a senior consultant pediatrician, and this is my colleague, Dr. Rajkumar, who's a consultant pediatrician and specialist in pediatric infectious diseases, and Dr. Karthik Narayanan, who's a senior consultant in pediatric critical care. So the topic for today we have divided as three. One is about the epidemiology, the agent, and the pathogenesis, which will be discussed by Dr. Rajkumar. The clinical spectrum will be discussed by myself. The diagnosis aspect will be discussed by Dr. Rajkumar, and the critical care management will be discussed by Dr. Karthik Narayanan. I request you all to mute yourself. At the end of the session, you can unmute and you can talk to us. Over to Dr. Rajkumar.
I welcome you all for this COVID-19 session in children. I am Dr. Rajkumar. I am a pediatric infectious disease specialist, and I shall be discussing you about the epidemiology of the virus and along with the diagnosis of the latest topic. Coronavirus, it is a single-stranded RNA virus. It is an enveloped type of virus. It has 4 subtypes in it. They include alpha, beta, gamma, and delta type of viruses. The beta coronavirus is the commonest virus that is related to human infection so far. The early infections known due to this viruses include NL63, 229E, OC43, and HKU1, and the SARS-CoV-1 and MERS are the earlier delta infections that are known so far, and now is the SARS-CoV-2. Coming to the viral structure, the virus has several parts. It has the classical spike proteins, giving us the classical picture of corona. The spike protein is the essential protein which helps in addition of these viruses to the epithelial cells in the humans. The other proteins include nuclear protein, membrane protein, and envelope small cell protein. The spike protein and nuclear protein overall help in evolution of the disease and also help in the diagnosis in terms of antibody and antigen production. The COVID-19 virus, which we are going to talk about in specific, this virus measures about 60 nanometer to 140 nanometer in size. This is similar to our influenza virus. This is a large and heavier particle. It is spread mainly by respiratory droplets and foamy transmission, as we all know. And this is the classical type of droplet infection. This is not an airborne type of infection. The airborne transmission is only possible in specific circumstances like aerosol generating procedures and nowhere else. In fact, the R naught for this virus is 2 to 3, meaning that if a person is infected, he can transmit this virus to another 2 to 3 people, but not beyond that. This again reconfirms that it is a droplet type of infection. The latency period for this virus is 3 to 7 days, meaning that from the onset of entry of virus into the person's body to the disease manifestation, it is approximately 3 to 7 days. The maximum period is 14 days. The period of peak infection is between 7 to 21 days, which is considered as a highly contagious phase. And this is the phase where patients encounter us, and we are at high risk of getting these infections too. The other aspect is the transmission can also occur in the pre-symptomatic period, which is the problem with this COVID-19 virus. Coming to pathogenesis, the ACE2 inhibitor receptors that are specific for SARS-CoV-2 are expressed in type 1 and type 2 alveolar epithelial cells of the human lung. And these are the classical receptors where these viruses go and bind, leading on to elevated expression and leading on to further damage of alveolar cells, triggering a series of systemic reactions and death in individuals. Coming to clinical features, Dr. Ganesh will be discussing about the clinical features.
Good afternoon. I'll be discussing about the clinical features of COVID-19 infection in children. As you all know, generally the children constitute about 1 to 5% of the total affected population. The recent data from US has stated about 1.7% of children are affected with COVID-19 virus. And generally most of the children, they are pretty asymptomatic. Why children are pretty asymptomatic? The reasons are the probable hypothesis are: 1, there is a stronger innate immune system in children. 2, as you all know, COVID virus needs the ACE2 receptors to go get attached to itself and create a problem. And children do have less number of ACE2 receptors. 3, most of the children, they are exposed to frequent episodes of cough and cold, which may be because of other viruses. and hence they mount a very good inflammatory response and thereby promoting the better clearance of viruses. 4. There may be cross immunity with other old type of coronaviruses. And 5. Children do stay at home. They are less exposed in epidemics and they are less tested. So these are some of the reasons why children are less affected when compared with adults. The clinical symptoms of COVID-19 infection range from common cold. It may be presented with bronchitis, bronchiolitis, interstitial pneumonitis, and croup, etc. And as I said earlier, most of them they are asymptomatic. Few of them have mild and moderate degree of symptoms, and very few of them they have severe and critical symptoms. Most of the symptoms are like any other viral infection. It may be fever, cough, cold, sore throat, myalgia, fast breathing and breathlessness, and some children they can have vomiting and diarrhea. The reason for this vomiting and diarrhea is the ACE2 receptors are also present in the intestinal epithelial cells, and that may be one of the reasons for the manifestation of vomiting as well as diarrhea. And what we look at once we know the symptoms, what we look at is we just look for the well-being of the child, the pharyngeal erythema, though there are many guidance which say that do oral examination only when it is absolutely needed, otherwise do not even perform. They can have tachypnea, wheeze, crepitations, stridor, and hypoxemia as defined by saturation less than 92% in human. And what are the risk factors? So the risk factors are generally infants, those who have neutrophil counts of more than 10,000, and when they have associated comorbidities. For example, a child with a chronic kidney problem, on steroids, children with chronic liver disease, children with chronic lung disease, especially those with interstitial type of pneumonitis, interstitial lung diseases, and those who are immunocompromised. Either they may be immunodeficient individuals or they may be immunocompromised following transplant or they receive the steroid therapy. And any children with underlying hematological disorders like thalassemias and those who are having the lymphoreticular malignancies or solid tumors, they are at risk of developing this corona infection. And what are the complications they can land up? They can have an acute respiratory distress syndrome, shock, myocarditis and pericarditis are very well reported, disseminated intravascular coagulation, encephalopathy, secondary bacterial infections. These children are at risk of developing secondary bacterial infections, and we have to suspect, especially when the counts are very high, and they may end up in a multi-organ dysfunction syndrome. And a study from Wuhan of the 1,391 children who were screened, 171 were confirmed to have the coronavirus disease as evidenced by the positive RT-PCR for nucleic acid for corona. And as you see, the predominant age group that is more affected is about 6 to 8 years and 11 to 10 years. Generally, more than 10 years, they are at risk of developing the coronavirus infection. And majority of them had contact history positive. And that if you look into the clinical presentation where they may be asymptomatic, that is, these children, they do not have the symptoms or they do not have the signs. But when you do the RT-PCR, in fact, their X-rays may be normal. And when you do the RT-PCR, they may be positive for the disease. So those are classified as the asymptomatic group. Upper respiratory tract infections, which forms the milder group, they'll have fever, cough, and cold. That's all. And when you do the RT-PCR for coronavirus nucleic acid, it turns to be positive. Moderate symptoms is when they have a features of lower respiratory tract infection, which may be either the pneumonia or the cooking glass opacitis. They may be having this feature and the severe pattern. And the study from Shanghai has reported that of the 243 children was seen, 34% of children had confirmed COVID infection. Majority of them were boys, and here also the clinical presentation is mild. Most of them they are mild to moderate category, and the asymptomatic is 4.4%. Over to Dr. Rajkumar.
So I shall be discussing all the diagnostic aspects of COVID-19. The diagnosis I would broadly differentiate into general and specific investigations, the microbiology and imaging. This is a slide that has been most commonly discussed in most of the forums. And this is a slide that gives a classical picture of the viral phase followed by the post-immune phase. And this also slide gives us the idea of investigations, when to investigate and how much to investigate. So in a patient who has milder symptoms, who may be as OP patient, you can consider just doing a basic blood counts like complete blood counts, which can show lymphopenia, along with imaging either a X-ray or a lung ultrasound if at all needed. Then in moderate symptoms, patients who get hospitalized, you may consider extra investigations like ferritin, D-dimer, prothrombin, LDH, etc. And again, imaging is warranted. In critical ill patients, you go for even further testing. And you go for ferritin levels, elevated you look for transaminases, and you look for blood gases. And along with that, we go for troponin P and along with interleukin 6, CRP, etc. So in general, the investigations are the classical findings of COVID-19 include leukopenia, which is due to a decreased immune response, thrombocytopenia, which is due to consumption coagulopathy, leukocytosis and neutropenia due to bacterial superinfection, elevated liver enzymes due to a liver injury, and elevated urea creatinine due to a renal injury, and elevated CRP, which indicates a severe viremia, elevated LDH, which indicates a lung injury, elevated ferritin, which indicates severe inflammatory response, and elevated D-dimer prothrombin indicating a DAVC, elevated troponin indicating a cardiac injury, and elevated interleukin 6, which is classified for cytoplasmic storm. Coming to microbiological aspects, these includes PCR, ELISA-based tests, and lateral flow assays. This is the timing of test that is recommended for COVID. I would compare COVID-19 along with dengue. The PCR is equal to a NS1. So in the first week, the PCR is useful, and later after that, your ELISA, IgM and IgG-based ELISA is more useful. Coming to the RT-PCR test, this is based on the envelope antigen along with RT-RT gene assay. This is useful in the first week of illness, as I said earlier. It is ideally 3 to 5 days after onset of symptoms. It's the ideal period to do this test to have a good result and good pickup rate. The sensitivity of this test is around 70% in the first week. The preferred samples are ideally nasopharyngeal oropharyngeal samples for patients. Sputum is generally avoided due to risk of transmission to the healthcare workers nearby and due to cross-contamination. Third, endotracheal and BAL are best yield. They are around 95% of the yield. RT-PCR is helpful in detecting active disease. Sampling techniques include nasopharyngeal swab and oropharyngeal swab. The technique is essential to have a good yield. For a nasopharyngeal swab, the swab must be deeply inserted into the nasal cavity and should elicit tears. The patients likely should flinch, but which means the swab is adequate and the target has been achieved. For oropharyngeal swab, ideally a gag reflex should be elicited. The swab should be kept in the place for 10 seconds while turning the swab around 3 times. This helps in getting a better yield. The PCR positive of various body fluids has been studied so far. For BAL samples, it is around 93%. For sputum, it is 72%. For nasal swab, it is around 63%. For breath biopsy of the by bronchoscopy, it's around 46%. For pharyngeal swabs, it's around 32%. For feces, it is around 29%. And blood and urine are relatively very low. The ELISA-based test, this is the second most common test that is recommended. This is a quantitative antibody-based test. This replaces the nucleotide capsid and spike protein antigens of the virus. This IgM is useful in this, and IgM, the sensitivity is around 75 to 85%. This should be ideally done after 5 to 7 days of onset of symptoms. But notoriously, IgM is found to be give false negative results. The reason is some people mount this IgM very late. Some people, even after 14 to 20 days, this amount of testing has been found to be useful, but not before that. Some patients have taken more than 14 days also for them to elicit IgM. Second is the IgG. This is the sensitivity is around 78%. This is ideally after 14 days of onset of symptoms. And overall, IgG is found to be better than IgM in most of the patients. So ELISA-based test, this is useful in confirming the disease, detecting asymptomatic infection, and also for assessing the overall disease burden. Coming to the rapid test, this is based on the lateral flow assay. This is an antibody-based test. This is a bedside test like the NS1 antigen for dengue. Here, the IgM sensitivity is around 93.8% and specificity around 95.6%. For IgG, it is around 88% sensitive and 100% specific. This is useful in confirming disease, useful in cluster containment staging, but not as an initial investigation. The other tests that are recommended are the isothermal loop mediated amplification PCR-based test, and second is the screening for COVID-19. These are the tests that have been evaluated so far, but currently not available in India. But if it comes, it makes a difference. In fact, the gene expert, this can be run like a regular gene expert MTP, so you can have your results within 2 hours. Coming to imaging, imaging is an essential part of COVID-19 management. Normally, the X-rays are non-specific. They may look normal. They may have variola infiltrates. They may have bilateral patchy opacities. Utilova consolidation, poor diffusion, however, are not classical of COVID-19. And whenever it is present, it rules out COVID-19. Coming to CT imaging, this is a more specific modality and is often equal to a PCR-like. The radiological findings may precede your symptoms. The classical findings include peripheral distribution, bilateral lung involvement, ground glass opacities, which are classical of COVID-19, along with the fine reticular opacities. In fact, your CT findings along with your PCR increases the sensitivity of COVID to almost 90%. Coming to lung ultrasonography, this is the most explored modality for COVID-19 in the recent times. The reason for use of ultrasonography is that in COVID-19, the classical lung involvement is found to be more of peripheral lung involvement than the central lung involvement. So any peripheral changes could be picked up by ultrasound. So this is the reason why ultrasonography of the lung is found to be useful. This is used as a triaging modality so far. In Italy, it has been well studied. The classical findings include thickened pleura, B lines, and multiple lobar consolidations, multi-lobar consolidations. So overall, the take-home message is that COVID-19 presents as an influenza-like illness in most of the children. Infants, older children associated with comorbidities have a high risk of severe disease. Specific investigations help in assessing severity. PCR is most useful, however, it's not completely sensitive. The CT imaging is more specific, and ultrasound is found to be useful nowadays. Thank you.
Having said about the clinical spectrum and diagnosis of COVID-19, usually children who are asymptomatic, they don't need any treatment per se. Only thing is self-isolation and just monitoring for symptoms is necessary. And for those children who have mild symptoms, they are just treated with supportive management in the form of paracetamol and medicines for cough and cold. Those children who wants the ICU care, especially those children who are very hypoxic, they have respiratory distress, they are hypotensive, and those children will need a PICU care. The outline and the guidelines for management of children in ICU will be discussed by Dr. Natraj.
Hello, good afternoon. I'm Dr. Natraj. I'm a senior consultant in pediatric ICU and emergency medicine, Rainbow Children's Hospital, Guindy. Dr. Karthik is caught up with some emergency, so I'll be taking over his place. So unless he comes, we'll be talking. I think if Karthik comes, I'll be. I think it just come. So the overview is, as you know, coronavirus. I'll be talking just 2 minutes before Karthik prepares himself. Coronavirus is a novel virus. So each and every passing day, every week, WHO or the CDC is coming up with newer recommendations. Initially, they said it's only droplet. Then they said there is a possibility of drops. Then they said masks is only for healthcare workers who have taking care of people who are sick or people who have symptoms. And now it's covered that cloth mask can be done, is compulsory for all of them. So each day it's been changing. So the dictum is none of us, to be very frank, has seen a corona. We hope that you don't see corona. Coronavirus in children is very, very rare unless you have pre-existing disease. Only the infants who are less than 1 year of age or adult, adult population was 60 plus, who have pre-existing diabetes, hypertension, COPD, chronic bronchitis, or any kind of chronic illnesses will have issues. So far we have actually seen very less number of pediatric people. Probably their innate immunity is better, or they have already some pre-existing or a variant of coronavirus which they have all seen, and now it's a cross immunity which they have developed, and the immunity is good. And the other thing is the ACR receptors is found to be very less in children. So all this is one of the reasons postulated for probable less severity in children. Now, according to WHO, they have divided the children who have come with coronavirus in category A, B, C. What does this mean? This means that it's category A of the group of children who have very mild symptoms, cough, cold, and fever. The category B is where they have severe cough, increasing breathlessness. But if a category A, if a child has congenital heart disease or nephrotic syndrome, or any patients with pre-existing symptoms have category A, mild fever, cough, they fall directly to category B. So for category A, they say it's only home quarantine. Category B or category A with all this congenital heart disease, all those things, category B require treatment. in the sense we don't have any specific treatment as of now for coronaviruses. So the only prophylaxis or the possible treatment options like hydroxychloroquine or chloroquine can be initiated along with oseltamivir if you are suspecting H1N1 with them. Category C is all those children with come with severe breathlessness. I think Dr. Karthik is ready. Is Dr. Karthik ready?
Okay, so now, hello, am I audible? Shall I proceed? Is it clear for everybody?
Yes. Yeah.
Okay. So coming to the PICU management of COVID-19. See, COVID-19, as far as we all know, that most of us have not seen any cases, and pediatric cases, as described previously, they are known to have a milder form of illness rather than a severe COVID-19 infection that has been classically described. So there is various lacunae in the knowledge of how COVID-19 actually presents in young children. Why? Because one is we don't have exactly what is the pathophysiology, how COVID-19 exactly is less severe in children. We don't understand that. And the second point is COVID-19 in children. What are the autopsy findings who died? Only a few children, around 3 children died, for which we have not done any autopsy. So we don't know what exactly is autopsy finding, why they died, what happened to the pathophysiology in each and every organ. And the third point in COVID-19 is what exactly is the therapy, and these children, whether they died due to exactly the viral infection or the manifestations of the viral infection, or due to an underlying interaction between the comorbid condition and the viral infection. So as far as we all know, we have to extrapolate most of these data from the pre-existing coronavirus epidemics like SARS and MERS, and as well as any other viral infection, how it interacts with children, and when we have to intervene. So, for example, there are two things. I'm using this whiteboard. I hope everybody can see. Once it comes into any child comes into contact with a viral infection, there are two kinds of responses that is normally elicited by the body. So one is these viruses. Is there or the board is not audible? We need a better marker. So there are two kinds of responses for a viral infection. One is a Th1 response, which is the cytotoxic mediated, and the T2 response, which is the helper cell mediated response. So in case of a cytotoxic cell mediated response, there will be a larger production of interferons. There will be more production of so they have pathogen associated molecular proteins. The viruses will release the pathogen associated molecular protein, and this will elicit two responses, a Th1 and a Th2 response. This is the CD8 plus cytotoxic T cell response, and this is CD4 plus. So what is the difference between these two responses is the CD8 plus response will have more of stimulation of the dendritic cells. There will be more of interferon gamma production, which is helpful in clearance of the virus. Whereas the CD4 plus response, it causes a stimulation of the immune system more. There will be production of interleukin 6, interleukin 1, and other kinds of pro-inflammatory molecules. And this fails to trigger the anti-inflammatory response, going into a cytokine storm. So how these two things manifest in the body? So this is the routine for all viral infections, how they go into. If it goes into the CD8 plus pathway, it will be a normal viral infection. When it goes through the CD4 plus pathway, then it becomes a viral sepsis. You all know it as viral sepsis. So what happens in a viral sepsis? Two systems are injured. One is the inflammatory system. The other is the endothelial system. These two, they couple and they cause a cascading effect. So the inflammatory system will have its effect on the endothelial system. The endothelial system will have its effect on the inflammatory system. They couple together and they create a cascade. And the preference of endothelial system, it depends upon what is the kind of the virus. For example, in dengue, it is a systematic endothelial response. If you take, for example, influenza, the endothelial response happens only in the lungs. Similarly, for COVID, predominantly the endothelial response happens in the lungs, and once it cascades, it goes into a system we're going to treat. So our can present in various various intervals of these system involvement. So there is a series like how they grade into mild, moderate, and severe. It can be graded into mild, moderate, single organ injury and a multi-organ injury. In severe form, you have a single organ injury and a multi-organ dysfunction syndrome. So before they have enumerated about the PPEs and the precautions that has to be taken at the previous session. So coming into a single organ injury, our first concern is to ensure oxygenation. So our patient can be completely with a mild URI, where you are going to start them on hydroxychloroquine and azithromycin, and you're going to send them to house for observation and quarantine. The second is breathlessness with oxygen requirement. So breathlessness with oxygen requirement is where we are going to can be in a COVID-19 situation. So how these three management are going to differ. So coming to the breathlessness severity, the most important thing is the oxygenation of the patient. So usually what we do is we see the oxygenation status or the PF ratio or the SF ratio. So if you don't have a ABG, you can see the saturation divided by the FiO2. So in normal nasal bronch oxygen, you deliver around 30% of FiO2. So if the SF ratio is less than 264, means like your child is going into an ARDS, or if your PF ratio say finding or any other finding, your child is going into an ARDS and this child requires oxygen, and probably this child will require an ICU admission. So once this child goes into the ICU admission, what methods of oxygen delivery we are going to use? So usually in any children or any viral pneumonia or an ARDS, if the PF ratio is less than 200, we don't wait for non-invasive measures. We directly go and intubate these patients. That is similar for COVID-19 also, or any SARS. So if the PF ratio is less than 200, we are going to intubate. If the PF ratio is between 300 and 200, there are dilemmas now. So suppose you have a NIV, you have HFNC, you have mechanical ventilation. So what to do? And mismatch. Suppose if your oxygenation is not improving within an hour or two, you consider direct intubation, because there are two kinds of school beliefs where NIV can produce excessive aerosolization and it can endanger the nearby patients also. So whenever you take into a PICU, it is always better to take into a negative pressure room, fearing the this thing of aerosolization. So once you take into the negative pressure room, suppose if you are in dearth of ventilation, you don't have adequate staff, you can try a non-invasive. It is better to avoid non-invasive ventilation. A much safer way is to have an HFNC in a negative pressure room. So start an HFNC, reassess in 2 hours. If the child is not improving, if the PF ratio is going down in 2 hours or the SF ratio is going less than 200, you start these patients on invasive mechanical ventilation. So the normal contraindications for HFNC and non-invasive ventilation follows even for a COVID-19 patients, like dynamic instability, poor sensorium, unable to handle upper airways. If these are there is no necessity for you to try for a HFNC or a simple oxygen. You can go directly and proceed with mechanical ventilation. So once you start mechanical ventilation, there are certain precautions or certain things that I would like to share in a PowerPoint.